Hello everybody, dear colleagues. Department of Endocrinology, Tbilisi State Medical University presents a lecture, Physiology and Pathology of the Hypothalamic Pituitary Complex. Lecture is given by the head of the Endocrinology Department of the Tbilisi State Medical University, Professor David Mitrivelli. Physiology and pathology of the hypothalamic pituitary complex. The pituitary gland, also called hypophysis, sits in the pituitary fossa sella turcica in the sphenoid bone and is anatomically close to some critically important structures. It is connected to the hypothalamus with the pituitary stalk. It's anatomy and relationships of the pituitary gland. Blood supply of the pituitary gland is very interesting. Branches of the superior hypophyseal artery form a capillary plexus in the median eminence and upper part of the pituitary stalk. This capillary plexus gives rise to the hypophyseal portal vessels, which transmit hypothalamic, releasing and inhibitory hormones to the anterior pituitary gland, and the posterior pituitary gland is supplied directly by the inferior hypophyseal artery. Venous blood from the pituitary gland drained by the number of veins into the adjacent cavernous sinus. The pituitary gland is divided into anterior pituitary and posterior pituitary. The anterior pituitary adenohypophysis is derived from an upward growth of the ectoderm of the roof of the oropharynx, Rathke's patch, which becomes pinched off. Here we can see the adenohypophysis, neurohypophysis, and hypophyseal stalk, the hypothalamo-hypophyseal tract, the hypothalamic area, and thalamus. Also, supraoptic nucleus and paraventricular nucleus are in the hypothalamic area. Here also we can see pituitary, which is situated very close with optic nerves, with chiasm of optic nerve, and because of this, in case of enlargement of pituitary, for example, in case of adenoma, macroadenoma, in case of supracellular growth of this adenoma, it may result compression of these optic nerves and results of visual problems. The posterior pituitary neurohypophysis is derived from the downgrowth of neuroectoderm, and each result, the Rathke's part pinched off, and this pinched off segment conforms the neural process, forming pars distals, pars intermedia, and pars tuberalis of the adenohypophysis. It's a pars tuberalis in circles in fundibular stalk. It's a lateral surface view. Metaform, or the mature form of the pituitary, we can see here pars distalis and pars intermedia, pars nervosa, infundibulum, and pars tuberalis. It's a median eminence. Anterior pituitary hormones. The anterior pituitary secretes at last 6 different peptide hormones. Each hormone is secreted by a specific group of cells. For example, growth hormone is secreted by the somatotrophs. It's a count of 50% of cells of adenohypophysis. Prolactin is secreted by the lactotroph, 10 to 30% of cells. Adrenocorticotrophic hormone, ACTH, is secreted by the corticotrophs, 20% of cells. And thyroid stimulating hormone, TSH, is secreted by the thyrotrophs, with 5% of cells. And luteinizing hormone, LH, and follicle-stimulating hormone, FSH, are secreted by gonadotrophs, 15% of cells. Here we can see anterior pituitary and anterior pituitary hormones and feedback control. Adrenohypophysis produce TSH, thyroid stimulating hormone. TSH stimulates the growth and function of thyroid gland. ACTH stimulates and growth of adrenal cortex. Gonadotropins, LH and FSH, they act on testes and ovarian. And prolactin, it acts on milk production, stimulates milk production. Growth hormone, which is produced by the adrenohypophysis, stimulates the liver function to synthesize and produce IGF, insulin-like growth factor 1. And IGF-1 acts on bone tissue, muscle tissue, and fat tissue. Growth hormone is the most abundant anterior pituitary hormone. It is protein with 191 amino acids with disulfide braids and a molecular weight of 22 kilodalton. Growth hormone stimulates the hepatic synthesis and secretion of insulin-like growth factor 1, IGF-1. It's a potent growth and differentiation factor. Growth hormone stimulates epiphyseal, prechondrocyte differentiation, and linear bone growth in children, stimulates lipolysis, increases protein synthesis, antagonizes insulin action, and stimulates phosphate, water, and sodium retention. Regulation of secretion of growth hormone. Growth hormone secretion is stimulated by the hypothalamic growth hormone releasing hormone, which acts where the G protein coupled receptor and increases cyclic AMP levels. Other factors that may stimulate the growth hormone release include stress, exercise, sleep, prolonged fasting, and ghrelin. It's a ghrelin, gastric derived peptide. Growth hormone secretion is inhibited by the IGF-1 negative feedback and hypothalamic somatostatin. Growth hormone secretion is pulsatal, 6 to 10 pulses separated by a long period, so during which growth hormone may be undetectable in the blood. Prolactin and its effects. Prolactin is a protein with 198 amino acids, 3 disulfide bonds, and molecular weight of about 22 kilodalton. Prolactin stimulates the proliferation of the breast, lobulo-alveolar epithelium, and lactation. It also decreases reproductive function by suppressing gonadotropin-releasing hormone, GnRH, and pituitary gonadotropin secretion, and by the impairing gonadal steroidogenesis in both males and females. Mechanism of action of prolactin. Binding of prolactin to its plasma membrane receptor leads to receptor dimerization. This is followed by a phosphorylation, the cascade mediated by the GAK and components of the STAT family, which translocate to the nucleus and regulate target gene expression. Regulation of the creation of prolactin also. Prolactin secretion is inhibited by the hypothalamic dopamine binding to D2 receptors. Prolactin secretion is stimulated by the hypothalamic tyrotropin-releasing hormone, TRH, and other factors, including estrogen, opiates, serotonin, and acetylcholine. Prolactin levels may be higher in stress, during sleep, and following cycling stimulus, exercise, meals, sexual intercourse, and an epileptic fit. adrenocorticotropic hormone ACTH. ACTH is a peptide with 39 amino acids and a molecular weight of 4.5 kilodalton. ACTH, melanocyte-stimulating hormone, and endorphins are products of the same gene, POMC, pro-opiomelanocortin. Effects of ACTH. ACTH stimulates the conversion of cholesterol to pregnenolone in the zona fasciculata and reticularis, and therefore stimulates the production of cortisol and adrenal androgens. Mechanism of action of ACTH. Binding of ACTH to its plasma membrane receptor in the zona fasciculata of the adrenal gland results in the activation of adenocyclase and increased cyclic AMP production. This leads to the stimulation of the steroidogenic acute regulatory protein, star protein, which mediates the transport of cholesterol through the cytosol to the inner mitochondrial membrane, where it is converted to the pregnenolone. ACTH is stimulated by the hypothalamic corticotropin-releasing hormone, CRH, as well as other factors, including stress, for example, acute inflammatory insults, and is inhibited by the cortisol. It's a negative feedback. ACTH secretion is pulsatil and exhibits a characteristic circadian rhythm with a peak at about 8 a.m. and nadir about midnight. Thyroid-stimulating hormone, TSH. TSH is glycoprotein with two non-covalent bond chains, alpha and beta subunits. The alpha subunit is the same as that of LH, FSH, and human chorionic gonadotropin. However, the beta subunit is unique to TSH, and TSH has a molecular weight of about 30 kilodalton. Mechanism of action of TSH. Binding of TSH to its plasma membrane receptor results in the activation of adenocyclase cycles and increased cyclic AMP production. TSH also stimulates phospholipase C activity. And effects of TSH. TSH stimulates every step of thyroid hormone synthesis and secretion. It also stimulates the expression of many genes in thyroid tissue and causes thyroid hyperplasia and hypertrophy. And regulation of secretion of TSH. TSH secretion is stimulated by hypothalamic TRH. TSH synthesis and release is inhibited by the thyroxine, T4, and threotyronine, T3, directly, where inhibiting transcription of the TSH subunit genes, and indirectly with the inhibition of TRH release. Other factors that may reduce TSH secretion include dopamine, somatostatin, acute non-thyroidolines, and increased human chorionic gonadotropin, for example, in early pregnancies. Gonadotropins in males. LH and FSH are glycoproteins with two non-covalently bound chains, alpha and beta subunits. They have a molecular weight of about 30 kilodaltons. And effects. LH stimulates the production of testosterone by Leydig cells in the testes, and FSH stimulates the spermatogenesis along with testosterone. Binding of LH and FSH to their plasma membrane receptors results in a stimulation of adenocyclase and increased CAMP production. LH stimulates testosterone synthesis by the acting on the star protein, which delivers cholesterol to the inner mitochondrial membrane, where it is converted to pregnenolone, the rate limiting reaction in testosterone synthesis. LH and FSH secretion are stimulated by a pulsated release of hypothalamic GnRH, gonadotropin-releasing hormone. Testosterone inhibits hypothalamic GnRH and pituitary LH production, negative feedback. Inhibin B, a glycoprotein consisting of two subunits produced by germ cells, inhibit FSH production. In addition, several other hormones, neurotransmitters, and cytokines modulate GnRH secretion. Effects of LH and FSH in females. LH stimulates the early steps in steroidogenesis and the production of androgens in ovarian theca cells. The LH surge induces ovulation and thereafter maintains the secretory functions of the corpus luteum, and FSH stimulates the recruitment and growth of ovarian follicles and their secretion of estradiol by stimulating the aromatase enzyme that locally converts androgens to estrogens within the ovary, mainly in the granulosa cells. Binding of LH and FSH to their plasma membrane receptors activates adenylyl cyclase and increases cyclic AMP production. LH stimulates the star protein, which transports cholesterol to the inner mitochondrial membrane, and the cholesterol side chain cleavage enzyme, which converts cholesterol to pregnenolone. FSH stimulates the aromatase enzyme that converts androgens to estrogens. Gonadotropins, LH and FSH, secretion is stimulated by the pulsatal GnRH secretion from the hypothalamus. The secretion of FSH and LH is fundamentally under negative feedback controlled by the ovarian steroids, particularly estradiol, and by the inhibin, which suppress FSH. The negative feedback effect on estradiol on LH secretion changes to a positive feedback effect as estradiol levels peak before the ovulation. For example, the estrogen peak causes the LH surge. Posterior pituitary hormones. The posterior pituitary stores and secretes oxytocin and vasopressin, also known as antidiuretic hormone. Vasopressin and oxytocin precursors are synthesized and packaged in granules in the cell bodies of specific magnocellular neurons in the supraoptic and paraventricular nucleus and of the hypothalamus. Here we can see the paraventricular nucleus and the supraoptic nucleus and how the vasopressin is produced from the external cells of supraoptic nucleus. Posterior pituitary hormone. The hormone precursors are transported down the axons in the pituitary stalk to the posterior pituitary. During this transport, they are enzymatically cleaved in the granules to give rise to oxytocin or vasopressin and neurophysin. Neurophyins act as carrier proteins for oxytocin and vasopressin during axonal migration. Vasopressin, the nonapeptide, also known as an antidiuretic hormone, binds to VR2 membrane receptors on the distal renal tubular cells in the collecting duct and causes the activation of adenylyl cyclase, the generation of cyclic AMP, and the activation of intracellular protein kinase. This results in the insertion of the water channel proteins, so-called aquaporin 2, into the tubular membrane, allowing a flow of solute-free water from the hypotonic luminal fluid into the hypertonic renal interstitium. This results in the concentration of urine. At higher concentrations, vasopressin binds to VR1 receptors on vascular smooth muscles and causes vasoconstriction. Vasopressin is also secreted into the portal circulation and, together with CRH, stimulates ACTH release from the anterior pituitary. Vasopressin secretion is stimulated by an increase in serum osmolality mediated by the hypothalamic osmoreceptors, decreased extracellular volume and blood pressure mediated by the baroreceptors in the carotid artery and aorta, and stress also. Vasopressin secretion is inhibited by the alcohol and cold. Oxytocin release is stimulated by the vaginal stimulation caused by the fetus during parturition, the sexual intercourses in the both sexes, and by nipple stimulation by the suckling during lactation. Oxytocin release is inhibited by the stress. Oxytocin stimulates contractions of the uterine muscle, which helps delivery of the fetus and the placenta. It may also help sperm transport in the uterus during sex. Another function of oxytocin is to stimulate the contraction of the myoepithelial cells that surround the alveoli in the breast to aid milk injection. So, key points of this part of lecture. The pituitary gland sits in the sella turcica in the sphenoid bone and has close anatomical relations to the optic chiasm and the cavernous sinus. Hypophyseal portal vessels transmit hypothalamic releasing and inhibitory hormones to the anterior pituitary gland. And the anterior pituitary secretes at last 6 peptide hormones: growth hormone, prolactin, ACTH, TSH, LH, and FSH. Growth hormone is secreted by the somatotroph, stimulated by the growth hormone releasing hormone. Prolactin is secreted by a lactotroph, inhibited by dopamine. ACTH is secreted by the corticotroph, stimulated by the CRH. And TSH is secreted by the tirotrophs, stimulated by the TRH. And LH and FSH are secreted by the gonadotrophs, stimulated by the pulsate gene RH. The posterior pituitary secretes oxytocin and vasopressin, also known as antidiuretic hormone. Vasopressin secretion is stimulated by an increases in serum osmolality and decreases the extracellular volume and blood pressure. Disorders: pituitary tumors and other cellular disorders. Pituitary tumors, adenomas, account for about 10% of all intracellular tumors. Pituitary adenomas may be classified according to their size. Macroadenomas is equal or more than 1 centimeter in greatest dimension, and microadenomas is less than 1 centimeter. Functioning pituitary tumors are associated with excess anterior pituitary hormone secretion. Non-functioning pituitary tumors, adenomas, are not associated with excess in anterior pituitary hormone secretion. Pituitary adenomas can arise from any type of cell in the anterior pituitary gland. Lactotroph adenoma, prolactin secreting, 26%. Corticotroph adenomas, adrenocorticotroph secreting, or non-functioning, 15%. Somatotroph adenoma, growth hormone secreting, 14%. Gonadotroph adenoma, usually non-functioning, 8%. Thyrotroph adenoma, thyroid-stimulating hormone secreting, 1%. Non-cell adenomas, non-functioning, 26%. And pluriformal cell adenoma, particularly prolactin and growth hormone co-secreting, 13%. Epidemiology. The incidence of pituitary tumors is 25 per million per year, peaking at around 30 to 60 years. Female patients usually present earlier than males. Pituitary tumors are almost always benign. However, up to 0.2% are malignant and spread locally. Lactotroph adenomas, prolactinomas, account for approximately 30 to 40% of all clinically recognized pituitary adenomas. Clinically recognized. Non-functioning pituitary adenomas account for 25 to 30% and are the most common pituitary macroadenoma. Non-functioning pituitary adenomas affect males and females equally and usually present in patients over the age of 50 years. The mechanism of pituitary tumorigenesis. The mechanism of pituitary tumorigenesis is largely unexplained, and pituitary adenomas are monoclonal in origin and are true neoplasms. Physiological and pathological hyperplasia of the pituitary gland should be distinguished from pituitary adenoma. Examples include lactotroph hyperplasia in pregnancy and lactation, thyrotroph hyperplasia in primary hypothyroidism, gonadotroph hyperplasia in primary hypogonadism, and somatotroph and corticotroph hyperplasia due to ectopic GH-releasing hormone and corticotrophin-releasing hormone hypersecretion, respectively. Clinical presentations. The onset of symptoms and signs of pituitary tumors is often insidious, particularly with non-functioning adenomas. Patients tend to present late and there is usually a delay in diagnosis. Patients with pituitary tumors may present with features of hypersecretion of pituitary hormones in functioning adenomas. Also, may be hypopituitarism, headache, compression of the surrounding structures such as the optic chiasm. Prolactin-secreted adenomas may present with galactorrhea, oligomenorrhea, infertility, and impotence. ACTH-secreting adenomas cause Cushing's disease. ACTH-expressing tumors may also be non-functioning. GH, growth hormone secreted adenomas, cause acromegaly. Luteinizing hormone LH and follicle stimulating hormone FSH secretion in LH and or FSH synthesizing tumors is uncommon and they are usually non-functioning, but they may rarely present with hypogonadism due to biologically inactive gonadotrophins. TSH-secreting adenomas, thyrotropinomas, present with secondary hyperthyroidism with or without a goiter. Hypopituitarism. A pituitary tumor, usually non-functioning, in the anterior pituitary may result in a decreased secretion of anterior pituitary hormones due to compression or destruction of the surrounding normal pituitary cells. Involvement of the posterior pituitary resulting in diabetes insipidus. It is less common. The order in which hormone deficiency develops is growth hormone first, followed by the gonadotrophins, ACTH, and finally TSH deficiency. Growth hormone deficiency. Growth hormone deficiency may present with fatigue, impaired physiological well-being, reduced energy, muscle strength, and exercise capacity, and increased abdominal adiposity, fat mass. LH and FSH deficiency in males and females. LH and FSH deficiency in males may present with reduced libido, impotence, infertility, loss of body hair, fine perioral wrinkles, and flushes. LH and FSH deficiency in females may present with oligomenorrhea, amenorrhea, infertility, dyspareunia, breast atrophy, and flushes. TSH deficiency. TSH deficiency may present with fatigue, apathy, muscle weakness, cold intolerance, constipation, weight gain, and dry skin. ACTH deficiency. It may present with fatigue, weakness, nausea, vomiting, weight loss, hypoglycemia, and loss of pubic and axilla hair in females. Antidiuretic hormone vasopressin deficiency. Antidiuretic hormone vasopressin deficiency may present with polyuria, nocturia, and polydipsia. Compression of surrounding structures. Etiology of supracellular disease may be different. For example, craniopharyngioma, dysgerminoma, ependymoma, gangliocytoma, and so on and so on. So it may be also metastatic neoplasm and supracellular arachnoid cyst, supracellular extension of pituitary tumor, and so on. Compression of surrounding structures in case of supracellular extension of the pituitary tumor. Supracellular extension of the tumor may result in involvement of the optic head, causing bitemporal visual field loss. Superior quadrants are initially affected, and these gradually progress to a bitemporal hemianopia that is characteristically unsymmetrical. Here we can see the pituitary adenoma, which results compression of optic nerves. Here in this picture we can see large cystic supracellular craniopharyngioma compressing optic head and hypothalamus, filling third ventricle up to interventricular foramen, thus causing visual impairment, diabetes insipidus, and hydrocephalus. Here in this picture we can see intracellular cystic craniopharyngioma compressing pituitary gland to cause hypopituitarism. Clinical manifestations of supracellular disease. It may be different. For example, somnolence, obesity or emaciation, or it's rarely, and adrenocortical insufficiency, or hypothyroidism, or hypogonadism, or precocious puberty, or diabetes insipidus, or growth deficiency dwarfism. Compression of surrounding structure. Stark compression causes hyperprolactinemia, which may cause hypogonadism. Other less common complications include third ventricle obstruction causing hydrocephalus, vomiting, papilloedema, reduced cholesterol level, and hypothalamic damage associated with diabetes insipidus, and change in food intake, temperature regulation, or behavior. A lateral extension of the cavernous sinus invasion may cause cranial nerve pulses and diplopia. Inferior extension may result in cerebrospinal fluid in area due to erosion of the sphenoid sinus. Headache in case of pituitary tumors. Headaches are caused by stretching in invasion of the dura. Large tumors with suprasellar extension may occasionally cause obstructive hydrocephalus. Pituitary incidentalomas. Pituitary incidentalomas are mass lesions, usually adenomas, that are detected following radiological imaging of the skull base or brain for another clinical reasons. Management depends on pituitary function and whether the optic helm is involved. Microadenomas that are intracellular and non-functioning may be followed up with an annual magnetic resonance imaging (MRI) scan to monitor their size. But macroadenomas that are non-functioning have not caused hypopituitarism and do not involve the optic height may also be followed up with an annual MRI. Investigations. Investigations in patients with suspected pituitary tumors include basal and dynamic pituitary function tests, pituitary MRI, and formal visual field assessment. In addition, patients with suspected syndromes of pituitary hormone hypersecretion, such as Cushing disease and acromegaly, should undergo specific investigations for these disorders. Basal anterior pituitary function tests are prolactin test, insulin-like growth factor 1, luteinizing hormone, follicle-stimulating hormone, testosterone in men, and estradiol in women, thyroid-stimulating hormone, and free thyroxine, and 8 AM cortisol. Prolactin. Prolactin levels can be elevated in non-functioning adenomas due to stalk compression, resulting in a reduction of the inhibitory effect of dopamine on prolactin secretion. However, prolactin levels of more than 4,000 milliunits per liter are usually due to prolactin hypersecretion from lactotroph adenomas, prolactinomas. Hyperprolactinemia due to decreased clearance of macroprolactin. Hyperprolactinemia may be due to decreased clearance of a complex of prolactin with immunoglobulin G, it's so-called macroprolactin. This condition is referred to as macroprolactinemia. Macroprolactin is not biologically active, but does get measured in routine assays, thereby causing falsely elevated results. The percentage of macroprolactin should be identified, and it's significant. The prolactin results should be amended accordingly. Misdiagnosis can be avoided by pre-treating the serum with polyethylene glycol to precipitate the macroprolactin before the immunoassay for prolactin. Insulin-like growth factor 1. Insulin-like growth factor 1, IGF-1, is the peptide that is synthesized and secreted by the liver under the control of GH, growth hormone. IGF-1, adjusted for sex and age, is low in patients with growth hormone deficiency. Growth hormone levels are affected by the number of factors, including stress and therefore growth hormone deficiency can only be proven by failure to respond to stimulation of dynamic tests. IGF-1 levels are high in patients with growth hormone secreting pituitary tumors causing acromegaly. LH, FSH, testosterone in men, and estradiol in women. Women with secondary hypogonadism have reduced estradiol with reduced or inappropriately normal LH and FSH. Men with secondary hypogonadism have reduced testosterone with reduced or inappropriately normal LH and FSH. TSH and free thyroxine. In secondary hypothyroidism, free thyroxine is low and TSH is either low or inappropriately normal. 8 to 9 AM cortisol and ACTH. In secondary adrenal insufficiency, 8 to 9 AM cortisol levels are low and ACTH levels are either reduced or inappropriately normal. However, cortisol levels, like growth hormone, are affected by the stress, and deficiencies can be proved only by a failure to respond to stimulation in dynamic tests. Vasopressin deficiency. Tests for posterior pituitary function include measurement of serum and urine osmolality and sodium concentrations and the water deprivation test. Dynamic pituitary function tests. Insulin tolerance test. Insulin-induced hypoglycemia and induced hypoglycemia stimulate the growth hormone and cortisol in secretion in normal individuals. Hypoglycemia with glucose level less than 2.2 millimole per liter and stimulation of growth hormone more than 20 milliunits per liter or 6 microgram per liter, and cortisol level more than 500 nanomole per liter. Patients with a basal cortisol below 80 nanomole per liter are very unlikely to have a normal response and may therefore not need the test. The insulin tolerance test, ITT, is contraindicated in patients with a history of epilepsy or ischemic heart disease. All patients should have a normal ECG before the test. Untreated hypothyroidism impairs the growth hormone and cortisol response. Insulin is injected intravenously at a dose of 0.1 units per kilogram of body weight. In case of acromegaly and Cushing disease, it should be more, 0.2 or 0.3 units per kilogram. Blood samples are taken for growth hormone, cortisol, and glucose, and blood glucose is also checked with a glucometer before insulin injection and after 30, 60, 90, and 120 minutes. A further insulin dose may be given if the patient does not become hypoglycemic by the 30 minutes. Once blood glucose is less than 2.2 millimole per liter and blood specimens have been taken, patients do not need to remain hypoglycemic. The false positive rate is about 5%. Glucagon test. The glucagon test may be done when an ITT, insulin tolerance test, is contraindicated. This test is slightly less reliable than an insulin tolerance test. In adults, 1 milligram of intramuscular glucagon is given. Blood samples are taken before glucose, taken for glucose, cortisol, and growth hormone prior to glucagon injection, and at 90, 120, 150, and 180 minutes. The criteria for adequate cortisol and growth hormone response are the same as those for insulin-tolerant test. The false positive rate is about 8%. The false negative rate for cortisol response is about 30%. Metirapone test. Some endocrinologists prefer to test the ACTH reserve using the metirapone test. Metirapone blocks the conversion of 11-deoxycortisol to the cortisol. Thus, in normal individuals, metirapone 750 milligram given orally every 4 hours for 24 hours causes a fall in serum cortisol. 8 a.m. cortisol should be less than 172 nanomole per liter after 24 hours of metirapone and stimulates ACTH secretion. The increases in ACTH leads to an increase in adrenal steroid synthesis up to and including 11-deoxycortisol. So 8 a.m. 11-deoxycortisol should be more than 289 nanomole per liter. In patients with ACTH deficiency, 8 a.m. 11-deoxycortisol after 24 hours of metirapone usually is less than 289 nanomole per liter. Pituitary imaging. MRI is preferred imaging modality for the pituitary gland. It can effectively characterize soft tissues and demonstrate the size of the adenoma and whether it extends outside the cella turcica. Patients are not exposed to ionizing radiation. The renal function must be checked before MRI within gadolinium signs. Some patients with impaired renal function have been reported to develop nephrogenic systemic fibrosis as a side effect of the contrast agent. In T1 weighted MRI images, the anterior pituitary is isointense with white matter. The posterior pituitary exhibits a higher signal intensity due to an accumulation of neurosecretory granules consisting of an ADH neurophysin complex packaged within phospholipid membranes. Following gadolinium administration, the pituitary gland and stalk enhance brightly. In patients with suspected microadenomas, both coronal and sagittal sections are required. Pituitary microadenomas are usually hypointense relatively to the surrounding normal pituitary tissue. This can be further clarified following enhancement with the gadolinium, as microadenomas take a longer to enhance. In patients with macroadenomas, pituitary MRI can detect involvement of the surrounding structure, for example, optic hiatus, cavernous sinus, carotid arteries, sphenoid sinus, orbit and temporal lobe, and the presence of hemorrhage. A computed tomography scan may be done when an MRI is contraindicated, for example, cardiac pacemakers, metallic clips on aneurysms, and except for never titanium clips, and any metallic foreign body in the eye, spinal channel, or close to a major blood vessel. Artifacts from the skull base and metallic dental materials can obscure and compromise the characterization of soft tissue. Treatment. The aims of treatment for patients with pituitary tumors include the treatment of pituitary hormone hypersecretion and the treatment of hypopituitarism, the treatment of space-occupying local compression effect of the tumors, And the space-occupying effects of pituitary tumors are treated with pituitary surgery. In some cases, pituitary surgery may be followed with radiotherapy. The indications for pituitary surgery include reducing local compression effects such as worsening visual fields, and surgery may also be indicated to prevent future compressive effect of the pituitary is shown to be growing over time on serious can and likely to cause problems before the patient dies of natural causes. Reducing excess hormone secretion, for example, in Cushing disease, in acromegaly, thyrotrophinomas, and prolactinomas, not responding to medical treatment also may be indication for pituitary surgery. When surgery is indicated, the transsphenoidal approach is the first-line surgery for almost every case. Patients must be informed of the possible complications of transsphenoidal pituitary surgery, and patients should be aware of the need for lifelong follow-up. It's a transsphenoidal approach for pituitary surgery. Complications of transsphenoidal surgery. Anterior pituitary hormone deficiency, it's about 10% for macroadenomas, uncommon with microadenomas. Among complications of transsphenoidal surgery is also bleeding, carotid artery injury, cerebrospinal fluid leakage and rhinorrhea, meningitis, diabetes insipidus. It's a transient, usually about 5%, and permanent is 0.1%. Eye complications, it's a visual deterioration, cranial nerve damage. In many cases, we may have failure of the surgery and also general anesthetic complications. In many cases, hyponatremia. Secondary adrenal insufficiency should be treated with hydrocortisone. Treatment of secondary hypothyroidism should be commenced only after excluding or treating adrenal insufficiency. Secondary hypothyroidism is treated with thyroxine if surgery is not imminent and with theophylline for 4 days preoperatively if the surgery is urgent. Craniotomy may be required for craniopharyngiomas, paracellular tumors, for example, meningiomas, and very large tumors with extensive supracellular extension and lateral invasion where transsphenoidal surgery is unlikely to achieve removal of a significant portion of the tumor. At the end of the first part of the lecture. Thank you for attention.